I'm Rajesh Khanna, and I'll be talking about PI. I practice in Beverly Hills and surrounding cities of Los Angeles. I don't have any financial interest other than I've written an educational book for the consumers, which is available on Amazon, and it helps the patients before and after the procedure. So PI stands for Presbyopic implant in eye, and it is used to fix presbyopia, which we all know is an inability to focus at close when corrected for distance. And incidentally, it also corrects hyperopia, myopia, and astigmatism. Most importantly, it delivers binocularity, and usually we perform both the eyes at the same time, but it can also be done one after another. Now, who is PI for? It's a subset of population from 45 years to 60 years of age who can also see 20/20 with visual aids like contact lenses and glasses. They don't want monovision with LASIK or SMILE, and they are usually active, high net worth individuals who want to be free of glasses at all distances. They rely on binocularity to play tennis, golf, pickleball, ski, and yes, they are very demanding. Like our traditional goal is we feel happy 20/20, but they want more. So that's why it's a whole paradigm shift. We are not only doing surgery, but we are sort of guaranteeing the outcome to be 20/20 at distance, 20/20 at middle, and 20/20 at near. So the end point is determined first, and we should reach it in 1 or 2 steps, but sometimes 3 or 4 are needed. And understanding the needs of the patient is paramount. So we spend a couple of hours listening to them, what will make them happy, and document everything so that they don't forget what was important to them before. And also it's very important to screen out unrealistic expectations, especially in Hollywood area where they think they'll get a better role if they can see better, you know. It's good to see the structure of the eye and revisit it, the line of sight. As you can see, the line of sight passes from the tear-corneal interface to the natural lens, which will be replaced by the intraocular lens and posterior capsule, through the long sea of vitreous, and finally onto the macula. So all this must be pristine. That means the dryness must be fixed, posterior capsule, vitreous will come to that. And remember, PI is not same as RLE. RLE is a misnomer to begin with because refractive lens exchange means we are exchanging the entire lens, whereas in PI, we know we are leaving the capsular support and the posterior capsula behind. So it's easier already for patients to understand since the posterior capsule is there, and when we YAG, what structure are we applying the laser to. And we are not just correcting refraction, but we are ensuring patient is not presbyopic anymore. For example, in an RLE, you could take a +8 patient, and this is a real case my colleague did, 30-year-old +8, made them 20/20, but they still needed reading glasses. So that's not the outcome with PI. They should be free of all glasses for most of the activities possible. And certainly it's not the same as cataract with an implant, because to begin with, cataract patients don't see better than 20/40, and sometimes they see even worse. So the base of comparison for a cataract patient for a 50-year-old who could already see 20/20 is different. So right immediately after surgery, they are comparing it with a 20/20 eye. And also the surgical techniques are different, and all the throughout the courses here, you see how difficult it is to remove a cataract. But we still have to be careful when operating for PI. Before the procedure, very important to treat dryness so we can get accurate measurements. And we have to, again, ensure there are no conflicting factors which will affect our outcome, namely performing OCT macula to rule out any macular degeneration, any pre-existing detachment, glaucoma, and also corneal thickness pachymetry to see if there's any edema or something. We have to use the latest generation of ILMaster 700 Lenstar or similar to calculate the length, and same way for topography. And the latest formulas to calculate the exact power. Because it's just not monofocal, we are wanting at all distances. When in doubt, especially with the post-LASIK patients, I like to aim a little myopic. Because if I have to go back and do laser, I prefer PRK over LASIK because of dry eye issues, etc. And though that's also acceptable. And then with LASIK, if it's a smaller 6 millimeter wound, it heals very fast. But also, if they're post-LASIK with some asymmetric astigmatism, it also gives me a chance to enlarge the optical zone, which improves the glare halos. But yes, we are dealing with some people with high expectations who lead a very active lifestyle and not like the cataract age group. And so I warn them about negative dysphotopsia and to ignore that from the beginning. Positive dysphotopsia or glare and halos occur more often. Like negative usually disappear by 4 to 6 weeks. But glare and halos, mostly they disappear by 3 months, but some 5-10% remain till 1 year. At least 2% in my practice we've had where they've gone on to 2 years. At that time, after 1 year, I give them the option if they want to go in for a lens exchange or something. But then they say, hey, no, we are happy, it's getting better, we are waiting. And by end of 2 years, I don't have anybody who is still having glare. But most importantly, because they're going to compare, especially when we are doing a couple's husband and wife, one gets to 20/21 and the wife is very unhappy. So we tell them each person is different because also neuroadaptation is required. So just the way we are hardwired, we might come to this same result at different times. Though the surgery is not very complicated, we have to, based on our calculations, place the incisions very accurately. And it's very important the rexes be 5 to 5.5 millimeter to cover the optic. Otherwise, there can be astigmatism created, and also the anterior capsule can fuse with the posterior capsule if the rexis is too big, and if it's too small, phimosis can occur. Then hydrodissection and delineation are important because the lens is not very hard and it tends to jump. And so we have to be careful not to go near the capsule. And the typical techniques of chop and may not work because the lens is softer, so we have to use a combination methods. Now I'm just playing this video to show because I'm putting through 2.2, patient is awake and they have to be very cooperative to give patient assistance. If they don't, then I enlarge the wound. And also to make sure astigmatism by different techniques we are using, veracity, etc., is placed.
Could you wrap up, please, sir?
Oh, we didn't start at that time.
I think time is...
Yeah.
Try to finish fast.
Oh, no, it never started.
No, it was there. You were watching.
It was?
Yeah.
I have gone only half it because I've timed this. It was to 8 minutes. Right? This
Yeah,
never started.
time supposed to was be 8 minutes. You can take 1 minute because time is over, so but we can give you 1 minute. So be
Okay.
fast.
I don't think it started. No. It was started? Yeah. Okay, well, I'll take 2-3 minutes extra then we have to remove all the viscoelastic just to show some expectations.
Hi, my name is Kevin, and I had my pie surgery. Hi, my name is Kevin, and I had my pie surgery yesterday. I was able to drive myself today. I've been able to see 20/20 today. It's a great blessing and a benefit. It's something I didn't think was possible.
So they're driving very fast, and as I was saying, we are just looking at 20/20, but they're
Hi, my
looking
name
for
is Mary
different things.
Ellen, and I had the pie surgery with Khanna Vision Institute, and now I have perfect vision. I had excellent care. They took great care of me. I was able to go back to work the very next day after the surgery, and my pickleball game has improved a lot.
So beyond 20/20, they are looking at other activities should improve. And just to go fast, posterior capsule is something which we treat differently, even for few cells or wrinkles. Rather than just opacity, we will yak to get the best outcome with these implants. And again, vitreous has been neglected, but now Dr. Steve Safran and others have emphasized, and we've been doing for 6-7 years, to clear any floaters which are present in the line of sight. And that helps a lot of patients which we previously neglected. So that's it. And this is how you can contact me. Thank you.
Thank you, Dr. Rajesh. So how you feel it is different among the other trifocals or bifocals or lenses?
So the lens, choice of lens will keep changing as the technology comes, but the philosophy remains same. Right now I'm using techniques, Symphony
Synergy.
OptiBlue.
Okay.
OptiBlue because that's giving the best continuous range.
But the Synergy is giving more range instead of Symphony.
So that's a very good question. When Synergy first came out, our European colleagues were raving about that. But in Los Angeles, people are driving at 80 miles per hour with all the lights, and they want very good distance. So Synergy, the distance was a little compromised. So I have to keep listening to what the patients are saying and adapt faster. With Symphony, previous version, there was a lot of cobwebs and they were unhappy.
Yeah.
That time I was using a combination of techniques 325 and 275.
Okay, yeah, multifocal
But with
and-
Symphony, OptiBlue, and again, I do a lot of things like measure the height of the patient. If they are tall, they
The
go
all
to
arm length is important.
Yeah, and what activities they are doing, if they are doing crochet, then we can adjust.
Definitely.
But that's why expectations have to be
But
dealt
my
with.
experience with the distance vision is not a compromise in Synergy also. I think you try again and you can use one eye Symphony, one eye Synergy. That will give you slightly
Yes,
better.
that's what I'm saying. Combinations will keep
Yeah.
changing.
Yeah. Thank you.